My name is Ashkon. I'm a third-year fellow in pediatric emergency medicine. So I'm a pediatrician who's trained to become a pediatric emergency medicine physician. And while I've had a handful of experience with septic patients, I'm by any means an expert, but though I do have a special interest. People may have conflicting opinions about whether I'm an expert in sepsis, but So this is a real case that I had. I'm a 4-year-old boy who was brought in for 4 to 5 days of fever, abdominal pain, or oral intake. His vitals in triage, he was febrile to 39, tachycardia to 150s, breathing 26, and his blood pressure was 86 over 50. So we'll get back to that. Our objectives for this talk are to review some definitions, because there's lots of definitions in sepsis, severe sepsis, and septic shock. Understand that children are unique in terms of their pathophysiology of septic shock and also in their management. And appreciate the importance of early recognition and initiation of goal-directed management of pediatric severe sepsis and septic shock. And finally, discuss some barriers and pitfalls, including some that we've experienced here that can impact effective implementation of pediatric septic shock guidelines. So the definitions are certainly very important. They're changing in the adult world of sepsis. So far they haven't changed in pediatrics. But just by means of review, this is something that we're probably all familiar with. In order to be in septic shock, you first need to have a systemic inflammatory response syndrome, showing at least 2 out of 4 of the following symptoms. So that's fever or hypothermia, defined as above, tachycardia or bradycardia, and that's, the bradycardia is really if the child is less than 1, and tachycardia is defined by standard deviations and norms, as opposed to kind of adult normals. Tachypnea, similarly defined, or being mechanically ventilated because of a respiratory reason and not like a neurologic reason or anesthesia. And then either a high or low white blood cell count or an elevation in bands. And I put this slide up just to show that, until you gain like a clinical gestalt over time, pediatrics is a bit more complicated than adult medicine, where we don't have kind of a single cutoff. We have various ages of children, obviously, and from a newborn to greater than 1 week, to an infant who's up to a year, toddlers and preschool-age children, school-age children, and adolescents. And our definitions of tachycardia, bradycardia, tachypnea, normal white counts even, vary by age as well as blood pressure. Now I will show you, we'll talk about, it's on all of our PALS card, but an easy way to remember normal blood pressures. But heart rates can be a little bit more challenging, and this is kind of where our electronic medical records can be, or our medical record systems can be helpful with pop-ups showing us that vital sign is abnormal, as well as cards on the back of our IDs. Our PALS card also had normal vitals. But these are kind of specific vitals as defined by international consensus of what defines SIRS specifically, not necessarily just normal. Another thing to get at here in this chart that's kind of big and lots of numbers is that there isn't a single one definition of sepsis and SIRS, and there are various different guidelines. And so when the idea is to recognize sepsis early, it's not necessarily to really have a strict definition where, oh, your heart rate's 179, you don't need this, you're not septic, I'm not going to treat you as septic. But rather, just to know kind of what you're looking for. And actually, even though vital signs are important, one message I'd like to convey is it's really about looking at the patient and touching the patient. So back to our case. So a 4-year-old boy brought in 4 to 5 days of fever, abdominal pain, poor oral intake. His temp was 39, heart rate 154, breathing 26. So would everyone agree that this child given his fever and tachycardia alone, also tachypnea is in SIRS. Another kind of type of chart that we've all become familiar with, certainly, is we go from SIRS to sepsis when we have a suspected or confirmed infection, which doesn't have to be a bacterial infection. You can have viral sepsis. And so generally all of our febrile kids, to some extent or another, we would probably think of as having sepsis, if assuming they're also tachycardic or have some other abnormality in their vitals or labs. Now, how do we get to severe sepsis? That's sepsis plus end organ dysfunction. And then here's kind of a definition of septic shock that kind of is more in line with the adult definition, and that's sepsis with hypotension is the definition of septic shock, but we'll get into kind of a little caveat of that. Because you don't need to be hypotensive as a child to be in septic shock. All right, so back to the case again. This child has had intermittent vomiting and abdominal pain, no cough, URI symptoms, or difficulty breathing. So maybe by raise of hands, is this child septic? Do we think this child has sepsis? Who thinks they have sepsis? It is a talk about sepsis. So, he's been vomiting, has some abdominal pain. Maybe he has an appendicitis, maybe he has a pneumonia, maybe he just has a viral gastroenteritis. But we think probably he's febrile and we think he has some sort of infection. And so I would say yes, this child is septic. So more specifically than just hypotension, and you notice that I didn't mention that that child was hypotensive, and we'll get into normal vital signs. But septic shock can further be defined as sepsis plus abnormal perfusion. So delayed capillary refill, decreased urine output, any other signs of cardiovascular dysfunction despite having received 40 cc's per kilo. So that's your child who seems a little dry, is febrile. Maybe you're calling them severely septic, but you've given them fluids and still their perfusion isn't normal. So that, in children, meets criteria for septic shock. All right. So this child was sent back to annex initially and looked quite different by the time he got back from the waiting room. So he was lethargic but arousable. I'm not afraid to use that word to describe him. And had flash capillary refill. So his capillary refill was a little too fast. So where on the spectrum do we think this child is? And why do we say severe sepsis?
His level of consciousness.
Great. So he has some signs of end organ dysfunction. His level of consciousness, so CNS dysfunction, and his capillary refill isn't normal. So it's not slow, but it's abnormally fast. So I would agree. So he's severely septic. Okay. So how do we define end organ dysfunction? Because end organ dysfunction is part of the definition of severe sepsis and also septic shock. So cardiovascular is a big, important one that we pay close attention to. You usually have to put your hand on the patient in part to assess this. So abnormal perfusion, and the definition of an abnormal capillary refill varies by kind of source, but a capillary refill greater than 3 to 5 seconds, or flash capillary refill, so it comes back in much less than a second, immediately upon pressing. Decreased urine output because you need renal perfusion from your heart to be able to urinate normally. And that's a definition that's more useful in the hospital in assessing, for those of you who are inpatient providers, assessing for decreased urine output. But if a child comes in with a history of decreased urine output, that is a sign for you. Decreased wet diapers, that they may not be perfusing their kidneys because of being dry or from being septic. And then hypotension is also another sign of end organ dysfunction, and specifically septic shock. You might in your labs find elevation in your lactate or some other metabolic acidosis. Respiratory dysfunction includes respiratory failure, whether that's needing, what that's just hypercarbia, or needing mechanical ventilation, or more specifically, having bilateral infiltrates on your chest X-ray and a need for oxygen. So that's getting into like ARDS. And then neurologic, being lethargic, irritable, altered mental status. And again, this is something I think that comes more and more as you become more and more used to taking care of children. There's a cranky child who's just a little fussy with their fever, and there's that child who's not a little more difficult to control, to console, lethargic. And then obviously we have various other organs in our bodies that can not function properly. So as we agreed upon, this child back in Annex was severely septic, and we all had to act. So a few more definitions, and then we'll get into some more interesting things. So on that chart early on, that was a consensus definition by the American College of Critical Care Medicine. And I find kind of their definitions that you saw on that chart, or blood pressures were almost seemed randomly defined, but they're actually kind of based on standard deviations, and it's not really so useful at bedside, and those consensus guidelines maybe are more useful kind of in the research setting. But something that I have found quite useful to define hypotension is the PALS, American Heart Association definition in pediatrics. So in a systolic blood pressure of less than 60 in a newborn, and in a neonate who's just recently born, then we use kind of MAP, should be about equal to their corrected gestational age. In 1 month old to 1 year old, a systolic less than 70, and then between 1 and 10, use the equation of 70 plus 2 times their age is the definition of hypotension. And then greater than equal to 10, then we use a systolic blood pressure of 90. Now, normotensive is actually, in this 1 to 10 year age group, is 90 plus 2 times age. So even though a child might not be hypotensive, you still might have signs that their blood pressure may be a little on the lower side. All right. Any questions about definitions? Because it can be, yeah.
How many tachycardia points do you get for screaming your full head off or having a regular fever?
That's a great point. So there are some equations that help that some hospitals use in their triage systems to correct for fever in terms of tachycardia. And certainly a screaming child is going to make them more tachycardic, and we don't have equations for that. So I think that's about quick reassessment, maybe getting them on a monitor, stepping away, helping them defervesce. I would give the caveat that with temperature though, if you're kind of reassuring yourself, you're pointing out a really good point that as I mentioned earlier, all of our kids are really tachycardic when they're febrile, and we don't treat them all as septic. And I think the important thing here is recognizing where severe sepsis lies. Certainly you can have your suspicion about sepsis and a child at risk for severe sepsis, but so those equations that correct for temperature are just going to decrease your sensitivity, so increase the likelihood that you might miss sepsis. So I'm not a big fan of equations to decrease their real heart rate would be if they weren't febrile, but rather kind of taking the child as a whole. I don't have that equation on top of my head. But certainly crying will falsely elevate your heart rate. And that's as a physician who's not taking vitals from triage, it's always helpful when the triage nurse writes screaming or kicking. All right, so, sorry, this might be one more definition. It's not really a definition, more of a kind of describing what pathophysiology is. So what do you think of as being, how do you define shock? What's going on with shock?
She's in hypertension, right? Like a loss of blood pressure.
So that's, but remember that we said that children don't have to be hypotensive to be in septic shock. But I guess the question I'm asking is, what's the what's going on in shock? Why is it problematic that you're hypotensive or that you're poorly perfused? Great. So I'm hearing inadequate tissue perfusion.
Can't meet metabolic demand.
Can't meet, exactly. So you have inadequate oxygen delivery to meet metabolic demand. And that may be because you're hypotensive and you're not perfusing, and so you're not delivering that oxygen. Or maybe because you're poorly perfused or too quickly perfused to meet that end organ demand. And then because your end organs aren't receiving enough oxygen, you have end organ dysfunction. That's kind of the pathophysiologic definition as opposed to kind of a vital sign and exam definition of septic shock. So oxygen delivery is a function of cardiac output as well as how much oxygen is in your blood and how much blood you have in your blood vessels. So cardiac output is then a function of heart rate and stroke volume. And children are mostly able to change their heart rate as opposed to adults. Adults are more able to change their stroke volume and less able than children to change their heart rates, especially those adults on beta blockers. And then, as you mentioned, Sam, blood pressure is then a function of of cardiac output. And so your end organ perfusion has a lot to do with your blood pressure. And your blood pressure has to do with both cardiac output and systemic vascular resistance. So children are very good at increasing their systemic vascular resistance when they're septic. And this is something, again, that adults don't do. Adults are more often kind of vasodilated and decrease their systemic vascular resistance. And so when the systemic vascular resistance increases, you can see if you kind of bring cardiac output over here, move, this A sign is just is directly correlated, so mean arterial pressure is directly correlated with cardiac output times systemic vascular resistance times some sort of constant. So that's cardiac output. If you increase your afterload or systemic vascular resistance, cardiac output is inversely correlated with systemic vascular resistance. So your heart is facing more of an afterload, and your cardiac output actually, at a given blood pressure, your cardiac output will actually go down. And we said that cardiac output is what is giving your oxygen delivery. So children increase their systemic vascular resistance and increase their heart rate to try to increase their cardiac output. But by increasing the systemic vascular resistance, they actually end up inversely, potentially decreasing their cardiac output at a given blood pressure that they may have. I might have talked too much during that slide. Right. So what do children do that is unique in terms of compensating? So we kind of touched upon this already. But children, in contrast with adults, can increase their systemic vascular resistance a lot. And they can also increase their heart rate. But they don't really increase their stroke volume that much. So what does that mean? That means children could be profoundly septic and be in septic shock without being hypotensive because their heart rate has gone up, they're squeezing really tight, they're maintaining their systemic vascular resistance, but their cardiac output is actually not that great, and they're not delivering to their end organs, and they're in septic shock, but they're not hypotensive. So they get pretty far relative to adults without showing hypotensive. So that's a late finding, and you're behind the 8 ball if you're only calling septic shock when children are hypotensive. And then similarly, adults can double their heart rates. Even though children are good at increasing their heart rates, adults can double a heart rate of 70, and that means double their cardiac output. But an infant whose baseline heart rate is 140 can't go up to 280 without, they're not going to fill their heart. They're not going to have, it's not going to be an effective way of increasing cardiac output. So that's just kind of a good example to show that children, while they are good at increasing their heart rates, there's only so good that they can be, and there's a upper limit on that compensatory mechanism. So then, how do children decompensate? So relative to adults, children in septic shock, and it's not a coincidence, there's a cube of ice on this screen, but cold shock is only something that happens in children. And one of the reasons it happens, and more kids tend to be cold shocky than warm shocky, and we'll get into the differences in those, is because children are relatively more hypovolemic on arrival to medical attention than adults, and also just even in the hospital. And that's because of a couple of reasons. So they have higher metabolic demand, so their baseline heart rates are higher, they're growing, they're using every calorie children use a lot of calories per weight, and every calorie that they use, remember those equations from biochemistry, every calorie is an ml of water, and so they're using up much more water because of their increased metabolic demand. And then also, while an adult can give themselves some liquid to drink, children and infants and toddlers can't, and they're relying upon their caregivers. And they're not going to power through a sore throat that they might have without a lot of coaxing or forcing by a caregiver or an IV sometimes. So they also have relatively less oral intake and end up being hypovolemic, and therefore can be more apt to rapidly deteriorate. And then also in septic shock, children's hearts are more susceptible to the toxic cytokines that are produced during sepsis. So the cytokine storm produced during sepsis creates a cardiogenic component. So when a child is in septic shock, they often are both hypovolemic and have some decreased myocyte function. So their hearts aren't working so well, myocardial function. And so that's why children present with cold shock. All right, so what does cold shock look like? We have low cardiac output. This is kind of a small arrow leading out of the heart that's meant to give, and the red blood is oxygenated blood. And high systemic vascular resistance, so children's bodies are clamping down peripherally to try to shunt blood to their brains and their brain and their kidneys. And so the periphery, their overall systemic vascular resistance is high. Again, adults don't do this unless they're dying at the very end of sepsis. And then what do they look like? What does a child in septic shock or in cold shock look like? What's that? Mottled. What are their pulses like? Ready. Delayed cap refill. So blood is kind of moving really slowly, and vascular resistance is high, and so your oxygen delivery is poor. And it takes a while. Your pulses are thready, your model, your capillary refill is delayed. Warm shock, you may have like a hyperdynamic heart with high cardiac output, or because your volume down and your preload is low, you might actually have low cardiac output. But the big thing here is that you're vasodilated peripherally, so your systemic vascular resistance is low. And then what do these children look like? Flash capillary refill, flushed, and their pulses are bounding. This child may have like strep toxic shock, or you can see that they're flushed and have some diffuse erythroderma. And because you're systemically vascular, you're dilated systemically, even though you're delivering, you're kind of getting oxygen to the tissues well. Kind of, if you think about in the capillaries, things are moving a little bit too fast for your cells to kind of take up that oxygen. So you're poorly extracting the oxygen. So in the end, the oxygen delivery is not meeting metabolic demands. I always find that a little confusing. So questions about pathophysiology. And we'll kind of touch upon some of these things again in management because they become relevant. All right. So the idea is early recognition and management. So this was a study of 180 or so children who were referred to University of Pittsburgh from other community settings, so pediatricians' offices, primary care offices, general EDs, and they were 186 children in septic shock. And they found that those children who had their shock reversed in the community prior to arrival were much more likely to survive. So this is kind of one of the earlier studies in children to show that early fluids antibiotics help survival. So those who had reversal of shock, you can see that nearly 100% of those in the graph on the top survived, whereas only around 60% of those who did not have their shock reversed survived. So you'd say, oh, maybe those kids who weren't reversed, they were just sicker. And they were. Those who died were sicker on presentation. But even adjusting for that risk of mortality, so there's kind of a pediatric risk of mortality score, even adjusting for it, those who had their shock reversed early on had a 9 times increased odds of survival. And then we kind of talk about some guidelines, and it kind of goes to show, in terms of following guidelines per se, is less important than kind of treating the septic shock. You understand guidelines, and there's definitely a lot to be said about kind of guidelines and how they can be helpful. But those children for which the American Academy of Critical Care Medicine guidelines and PALS guidelines /PALS guidelines were followed, that's one guideline, had a 6-fold increased odds of survival, and that's adjusted for their mortality risk up front. But the kids you were even more likely to survive if your shock was reversed. So following guidelines helps with survival, but really it's important that whatever manner you have, you're reversing shock if possible. And then for every hour of persistent shock, a 2-fold increased odds of mortality. And then for each hour of delayed resuscitation, a 50% increase in odds of mortality. So this is in the community. This is before arrival to our pediatric emergency department. I imagine these are providers from not just CHO, but all over the place. Yeah. And do some people work in non-pediatric settings? So you're important. And sometimes some of the challenges in non-pediatric settings are things like having enough kids to get an IV. But this is kind of, this early study that's kind of talked about throughout the literature advocates for early reversal of shock. So even in the community, you have every hour, remember, every hour increases that child's risk of mortality. And so placing an IO if you can't get an IV is really important and not delaying. All right, so how do we recognize things early? One way to recognize shock early is really to make use of the pediatric assessment triangle. Has everyone seen the pediatric assessment triangle, used it, loves it, maybe? So pediatric assessment triangle is something that you can get, that the triage nurse can see the patient in the waiting room and assess them across the room and say that child is sick. And so there's 3 parts. The first one that you'll be able to see from across the room is their appearance. Then maybe getting a little bit closer to see what they're breathing, and lastly circulation to their skin. So appearance may be lethargic or irritable, their gaze may be off, they may not be looking at you right. And if the one take home of that pediatric assessment triangle is that if your appearance is not normal, that child is potentially sick. And then circulation is kind of more relevant to shock, is going to be pallor, cyanosis, modeling, and if you're touching the patient, then that would be capillary refill. But you don't need to touch the patient for the pediatric assessment triangle. So this is a 5-year-old with vomiting who's alert, talkative, and has mottled extremities. How would you describe this 5-year-old's across the room pediatric assessment triangle? What's that?
Sick.
So potentially sick. What's their appearance? So their appearance is potentially normal. They're alert, talkative, interacting with you. Their work of breathing, so they don't mention anything about work of breathing. And their circulation, so their circulation is what's abnormal. And APLS would say that kind of in this group, in children who just have abnormal circulation, but normal appearance, these children may be in kind of a compensated shock. And in this talk, we're not really getting into compensated versus uncompensated per se. But this is a child who may be kind of early on in that spectrum of sepsis. So a 10-year-old with ALL who has fever, lethargy, and pallor. What's abnormal on the pediatric assessment triangle here? Appearance and circulation. Great. So this child, APLS would say, using the pediatric assessment triangle, from across the room, no vitals, you can say that this child is in decompensated shock until proven otherwise. I mean, the kicker is that the child is ALL, and certainly that child wouldn't be waiting in most ER waiting rooms, but all right, so we've talked about this. Has everyone heard of this term, the golden hour? So surviving sepsis campaign, we want to normalize, we want to kind of get fluids in, get antibiotics in, and normalize vital signs perfusion in the first hour if possible. So in the first 5 minutes, in any child in shock, so even if you're not hypoxic, you're getting non-rebreather on, you're getting some oxygen on, and you're establishing IV access or IO access. And so if you have made a couple attempts at an IV and you're considering a child to be severely septic or in septic shock, that's about time to put in an IO. Proximal tibia is a good place in kids that we often do. And we'll talk about how there's certainly a lot of barriers to IO placement, just kind of culturally, and all of our hearts are like, I don't want to hurt this child, but you're really trying to save this child's life. And so these first 5 minutes are really important because it's what's going to allow you to give fluids and antibiotics, and it's really important to, while you're maintaining their airway here, and while are any providers here providers that intubate as part of their job? But you may supervise doctors in their intubations, and or nurse practitioners. And so here is when maybe a new certainly you'll need IV access. And while you're maintaining airway, it's important to fluid resuscitate a child before intubating them, however possible, because you want their tanks to be full, because once you intubate, you increase their introthoracic pressure, you decrease their cardiac preload, and they can crash on you. So you want to resuscitate a certain amount before actually establishing a formal airway with intubation. So in the first 15 minutes, and this may look a little different than your PALS card, and again, I'm acknowledging here that there's different ways to skin a cat, but these are from the ACCM guidelines. So you can do up to 60 cc's per kilo in the first 15 minutes. So how do we deliver IV fluids in septic shock? Orange shot. Push pull, fast, as fast as we can. We always do this in the pediatric sim center with the second-year pediatric residents, where they'll ask us to put the ALL patient give the patient some fluids, and we'll just start some fluids casually until they tell us specifically to give it quickly. And so push pull's the fastest way that you can give fluids. And has everyone kind of done push pull? So just in case, don't have a diagram, but and you don't have to have a 3-way stopcock to be able to do this, but it's really about getting a good large syringe. Depending on the size of the child, you might not need that much to give 20 cc's per kilo. And you're administering that with kind of pushing through the IV. You can also set up a three-way stopcock where you have the IV, three-way stopcock, and the patient. And you kind of keep turning, pull, push, pull, and push to the patient. So you can give this fluid. I mean, our PALS card will say in the first hour, but you can give it as quickly as over 5 minutes. But the bottom line is just give fluids as fast as possible. In these first 15 minutes, you're diagnosing and treating hypoglycemia. So certainly, hypoglycemia is not good for the brain, as well as poor oxygen delivery. And hypocalcemia is not good for the heart, so it's not going to affect your cardiac output. And then giving your antibiotics, or at least having them at bedside in the first 15 minutes. Yes?
So, as a longtime oncology nurse, back
Yes.
in the day on the floor, we were clearly instructed to never use a deep line when we suspected sepsis, as in flushing it because of the possibility of dissemination.
Mm-hmm.
And then it seemed like that changed over the years. So what is like the most up-to-date thinking about that?
Yeah, I would say use the access that you have. Definitely, it's great to give fluids and antibiotics through the access that you have, with the caveat that when you flush that line, if you suddenly notice that your patient becomes flushed and hypotensive, you probably shouldn't be giving your fluids through that line. You can certainly deliver your antibiotics because you're treating a line infection, assuming,
Because we used to be like strictly counseled to not mess with their Broviac at all. And we were always trying to get a peripheral access on the chance that their line was infected.
Right.
But obviously that has changed.
Yeah, and actually the point of access, your central lines are kind of where you're most likely to be able to give your inotropes and your pressors longer term, but you can start your inotropes and pressors through peripheral access as well, even though we're kind of shy about doing it, because if the child needs that. Is there another hand? So if you're recognizing that this child is in septic shock early on, you might actually have inotropes at bedside and order them from your pharmacy. And antibiotics, you want to give them as soon as possible. Certainly the goal is to get all this in within an hour. And when do you stop giving fluids? So I can think of 2 scenarios when you would stop. So when they've normalized, so your capillary refill, your blood pressure, your heart rate are now normal, you can probably stop. And then when might they not tolerate any more fluids? Yeah, exactly. So if you start developing crackles, more hypoxia, if your liver goes down, so they may be fluid overload and reach the upper end of their ability, their tank is full. So then you've got your IV access, you've sent off your labs, your hypoglycemia is now normalized, you've maybe even given all your fluids. I know it's hard to give us that much fluids in 15 minutes, but do your best, give them as fast as possible. Then you're starting to give your antibiotics. So what sorts of antibiotics are you giving in your settings in septic shock? What are you giving first? So I heard Bank, I heard Grocefin. Great. Oh, in your neonate Amgen. So ceftriaxone is certainly first because you can give it more quickly. And in like your fever neutropenic patients, your gram-negative organisms are what's going to kill you next.
Partial to the emergency room. Trauma sent partial to the
And then
emergency room.
plus or minus broader
Trauma sent
spectrum
partial to the
things.
emergency
So in
room.
our protocol, instead of ceftriaxone, we give Miro when we're diagnosing septic shock. In neutropenic patients, and then we're potentially also giving neutropenic patients in septic shock. We're potentially also giving tobramycin in patients who are post-BMT. You're completing fluid resuscitation. You can continue to give more fluid beyond the 60 cc per kilo, and you're starting your pressors in this first hour. So your PALS cards will kind of talk about cold shock, who is normotensive, starting dopamine. The convenient thing about dopamine is that it's pre-mixed. It may be readily available in your Pyxis, is it? Pyxis, yeah. So it's something that we can start earlier. There's definitely different consensus on whether or not we should just give. So dopamine, in order to work, has to be converted into the periphery into these other things of epi and norepi. And so your infants less than 12 months may be less able to do that, and so there's an idea that they may be less able to convert dopamine peripherally. And so just going for your epi or norepi. So when do we use epinephrine? Cold shock. And we use norepinephrine in warm shock, and that's because norepi has more of a peripheral squeeze, increases your systemic vascular resistance when you're warm and peripherally vasodilated, and epi kind of has a little less of that and treats more of your cardiogenic component. In adults, it's generally just norepi. So epi and dopa are kind of inotropes here that in the adult world aren't used very much. And then considering hydrocortisone in kids who may either be a setup for adrenal insufficiency or if you know they're adrenally insufficient. So just a quick comparison between our PALS card and the ACCM guidelines, the American College of Care Medicine, is really just that ideally you want to give your fluids quickly, but otherwise kind of these two guidelines are in agreement. So there's no strict cutoff of how quickly you should give fluids, just as fast as you can. So and then in terms of management, because of the differences, how are children different than adults? Remember we said that children are more hypovolemic on arrival. They have increased metabolic demands. They've had decreased PO. So they'll need proportionally larger amounts of fluids than adults up front. So that's another reason to give fluids quickly. They're more likely to have a cardiogenic component. So they're more likely to need inotropes. We're rarely using kind of vasodilators in the emergency department or in a community emergency department. It's maybe the neonates who we would do like dopa and dobutamine